A commonly clinically encountered situation that is high potassium in the blood. Residents working in the casualty, ICU, or in the ward at a particular point of time, they will have struggle in making the diagnosis. Especially a first year resident will come and say, "Sir, I have gone through Harrison. Fully, still I could not solve this case. I want to send that TTKG, transtubular potassium gradient. Still, I could not proceed ahead. What could be the diagnosis?" So the topic of discussion is related to that, which is high potassium in the blood, hyperkalemia. Hyperkalemia. We are going to see simply how to approach a case. The topic is at the level of MD level discussion, which is required for the practical management and diagnostic approach, so that you will get the confidence in the subject. One more info I want to give here is, in Harrison, the things all are given but haphazardly, especially hyperkalemia. A first year resident might find it difficult to consume and apply at the clinical side. Let me put it in a simple way in this video. Hyperkalemia, potassium more than 5.5 milliequivalent in the blood. Etiology, only three for the actual causes. What are those three? It could be increased intake or decreased excretion. Patient is not excreting properly. Third, intracellular shift. From the intracellular compartment, the potassium came to the extracellular. Only three causes of actual hyperkalemia. True, in the patient, in the blood, inside the patient, potassium is high. But what happens? We get the report from the lab. After taking the blood from the patient is not having hyperkalemia, but the report is showing hyperkalemia. What is that? It is called pseudo or falsely rise in the potassium. It is nothing but after taking the blood from the patient, because of some kind of issue inside the vial, potassium is being released from inside the cell, from the cell to the outside where it is being measured. Vigorous shaking of the sample before the processing, any kind of cellular lysis which can occur whenever the total cell is high, total white blood cells, which can occur in leukocytosis, high amount of platelet might get lysis, thrombocytosis. But a simple scenario is a vigorous shaking of the sample before processing, any kind of mechanical trauma for that matter, that causes false rise in the potassium. That is called as pseudo hyperkalemia. In the report, potassium is high, but in the patient, it is normal. That we have to rule out. So one is pseudo hyperkalemia. So once we come to the actual, as we seen, only three causes. So to make the diagnostic approach, you have to be very clear regarding the important clinical info related to that. First, let us take increased intake. Increased intake is unlikely to increase the potassium in most of the patient, because kidneys maintains the homeostasis. Whatever the amount they will take, it usually excretes through the kidney. Unlikely. On an average, 1 milliequivalent per kg is the requirement of potassium for a particular person. Even if a person takes it at a higher quantity, unlikely the higher intake will cause hyperkalemia. So this is one of the least important cause among the hyperkalemic causes. But in patients whose kidney functions are not there, or for example a patient is dehydrated or any other risk factor, in those situations hyperkalemia can be due to increased intake. One important info you should know: if kidneys are functioning well, it manages. If not, the potassium might rise because of the increased intake. As I told, normal is 1 milliequivalent per kg is the requirement. If it is taken in 2 times, 3 times the higher amount with some risk factor, dehydration or renal dysfunction, yes, it might cause higher potassium in the blood. First we have seen. Coming to the second, the cellular shift from the intracellular to the extracellular. Most common scenario is acidosis. Acidosis, due to any reason, H plus is there, which will get because of some mechanism. Let us take in that way, because otherwise if I go into mechanism in detail, it will be like a MCQ kind of discussion, multiple choice question type of discussion. So mechanism I am not going into detail. Acidosis, H plus is there, goes inside, potassium comes out. Acidosis is an important reason, where from the intracellular potassium comes to the extracellular. Then any kind of high osmolar solute pulls the potassium out, can be. Even in diabetes, extremely high sugar can pull it out. Mannitol, any high osmolar can pull it out. Osmolar drag can be there. This can cause intercellular shift. Rhabdomyolysis, tumor lysis syndrome also causes potassium into the extracellular compartment. So if you take the shift as a whole, you can remember mainly acidosis. This is what you're going to handle clinically. Glucose and high any osmolar subject can pull the potassium out. Okay. Second we have seen. Coming to the most important third one, which is the most important one. Decreased excretion. It is as simple as kidney dysfunction. Can be acute kidney injury, can be chronic kidney disease. The excretion is decreased. Okay, let us take simple, but one more situation where kidneys are not excreting despite AKI and CKD is not there. Where it can occur? Whenever there is ROS blockade. What is that ROS blockade? Renin, angiotensin, aldosterone system blockade. So this is the most important discussion, which Harrison have given as a multiple tabular columns, tabular column with multiple heading. In toto, what is that? It is renin, angiotensin, aldosterone. It acts on the kidney, where it try to push out the potassium. This is the entire arc. This is the renin, angiotensin, aldosterone system. Aldosterone is secreted from the adrenal. Glomerular. Adrenal is having 3 layers, as we all know. Glomerular, fasciculata, reticularis. Aldosterone also comes, cortisol also comes. For the simple understanding, as of now, remember aldosterone is the primary homeostatic regulator of the potassium, out of which 5 to 10% cortisol can control. Cortisol being controlled by ACTH through pituitary. So this is basic pathophysiological thing which is required to understand this hyperkalemia. Now coming to one by one. Anything which blocks this arc, starting from renin. Renin is secreted from the JG cells in the kidney. Renin, JG cells, angiotensin, aldosterone act on mineralocorticoid receptor, ENaC channel, and potassium being excreted. Take any problem in this arc can cause hyperkalemia. First we have seen, second we have seen, now third we came in that kidney dysfunction or this arc, renin, angiotensin, aldosterone receptor which acts on the kidney, this arc problem, where it can happen. Problem with the renin inhibitors, angiotensin, the drugs, angiotensin converting enzyme inhibitors, aldosterone blocker, ARBs, telmisartan, losartan, any sartan for that matter, angiotensin receptor blockers, mineralocorticoid antagonist, any drug which blocks this causes hyperkalemia. And this is the most important clinical scenario you are going to handle in casualty. Okay. Let me put few more info which is there in the textbook so that your confusion will be cleared out. So this I have told renin, angiotensin, aldosterone and the receptor. Not only drugs, many a times in diabetes the JG gels, juxtaglomerular cells, can't secrete renin because of some kind of pathology, vasculopathy or whatever it is. This renin is not secreting in diabetes. If renin is not there, this arc is affected. That is why in diabetes there is hyperkalemia, which is called as terminologically hyporeninemic hypoaldosteronism. Hyporeninemic hypoaldosteronism, because this JG cells is not secreting renin because of the diabetes, some pathophysiological process. Diabetes is the important condition where patient presents with casualty because of high potassium, called as hyporeninemic hypoaldosteronism. JGGLs, if adrenal itself is at risk, adrenal is not secreting aldosterone, what to do? What are the causes? Tuberculosis, cortisol secreting issue because of the pituitary ACE. These are the rare causes which Harrison has given. Like just for the discussion sake, I am telling ACTH, cortisol, that also have some adjuvant effect that might cause this potassium issue, hyperkalemia, because this arc, renin, angiotensin, aldosterone system arc is there, supplemented by cortisol. That is not there, it won't happen. Adrenal can be destroyed because of any other reason, for example like chemotherapy or the particular drugs, it can cause it. Clinically, most common is diabetes and drugs, that's all. Okay. Then comes the question, sir, what about those receptor problem, mineralocortical receptor problem, pseudo hypoaldosteronism? The name itself says pseudo hypoaldosteronism. It is not acting on the receptor. Everything is high. Aldosterone is high, but it is not acting. Aldosterone is high, but it is not acting on the receptor. Clinically, it presents as hypoaldosteronism, but aldosterone is high. That is called pseudo hypoaldosteronism. Whatever the pathophysiological process you take, which might be important for the multiple choice question, but here understand this arc is affected, renin, angiotensin, aldosterone arc. Multiple times I have told this because this is where the entire understanding of hyperkalemia is there. Okay. This renin secretion can be affected by NSAIDs, some transplant medication, cyclosporine, those things which are mentioned, but unlikely you are going to encounter clinically unless you are working in a nephrology division. Okay. And that's all. Almost these are the commonly encountered scenarios. Receptor blocker, I will come to that. So in summary, let me see the time. Look, in summary, increased intake unlikely to cause unless there is a risk factor. Shift, mostly acidosis or any kind of lysis, rhabdomyolysis, tumor lysis. This third one is the decreased excretion in that RAS system blockade. RAS, I mean renin, angiotensin, aldosterone blockade. AKI, CKD, even in congestive cardiac failure, because of some pathophysiological process, kidney goes into AKI, or in some technical terms, if I have to put, the distal sodium delivery is impaired, so patient will go into hyperkalemia. That's all. These are all the in total causes of hyperkalemia, which you are going to see at the ground level. Okay, we have seen the etiology. Coming to the diagnostic approach, this is where the residents having many doubts whether to do TTKG or not and all. So most of the info you are going to get from the patient age and the clinical presentation. If you see 100, let us put it as 1000. If you see 1000 cases of hyperkalemia, hardly 5 to 10 cases might be some receptor related problem. Remaining 990 might be related to diabetes, drugs only, which is having diagnostic problem. Otherwise, most of the time it is renal dysfunction. Hyperkalemia is due to CKD or AKI. or subtle dehydration were presented in renal dysfunction. This is the most common thing. So Harrison didn't mention regarding the age and how to approach. They directly gave potassium. But as a residents, you should be aware that in the casualty, you are not going to see only the potassium, you are going to see the patient as a whole. From the history, you will easily come to know why the potassium is high. If a patient ages 60 years, patient is on some medication, RAS inhibitor, that is the reason. RAS inhibitors could be the reason. Ask the history in detail. Patient might be diabetic. One more thing, resident will say, sir, I have asked the history, diabetes is not there. Yes, patient history was diabetes is not there, but you have to check the HbA1c. Many a times patient will turn out to be diabetic. HbA1c. Last week also we have seen a case where HbA1c was 13, but there was no history of diabetes. So as a medicine resident, you should be good in the assessment. Okay. So you have to keep the possible DDs. 60 years, this could be the possible DD. And the receptor problem more likely to occur at the younger age, 20 to 40. Let us divide age wise. Less than 20 years, 20 to 40, 40 to 60, more than 60. You are going to handle hyperkalemia between 40 to 60 more often than in the younger age group. Less than 20, leave out, it could be very rare. Okay. Because of AK and CKD only. 20 to 40, any receptor problem can be there. 40 to 60, above 60, you ask the history, you will come to know. If patient is a hypertensive, hypertension might have induced renal damage. That might be the cause of the hyperkalemia. Okay. Because they will say, sir, only hypertension is there, how to approach. So in the diagnostic evaluation, always look at the age, ask the history and look it. Another example, let us take a potassium of 7. The patient came to casualty. Here two details are missing, age and why the patient came to casualty. Only if you know, you will be able to make the diagnosis. For example, let me put it. Patient is 65-year-old, not a diabetic, not a hypertensive, came to casualty in low BP, low sugar, and patient potassium is 7. So let us take HbA1c report also came, which is 5. So what is the clue? The clue is age is on the bit higher side, hypotension, hypoglycemia both are there, all features suggestive of low cortisol in the body. Addison disease could be. You have to pick up the other parameter which is adding info to the clinical scenario. Only looking at the potassium report, you are not going to solve the case. You take the history. Another example, again potassium 7, patient age is 25, presented with sudden weakness, no other symptom, no family history, not a diabetic. So what it could be? Look at the blood pressure. If there is aldosterone deficiency or problem, blood pressure will be on the lower side. Patient might be having acidosis. If only potassium is the problem, BP is normal, then it could be the receptor problem like any syndrome, pseudo hypoaldosteronism, whatever it is, which is very rare. History will be very typical. That history you might not have heard in any other patient. So from here onwards, probably from tomorrow, try to see 100 or 50 cases of hyperkalemia in the subsequent years, and just remember how many are only diabetic and drugs and CKD including that. Apart from that, you are not going to see any other case. Even if it is, you can easily make the diagnosis. One more thing is that painkiller NSAID, that also causes, as I told the mechanism. So this is in total summary related to the approach. It's already 15 minutes, video is getting lengthy. Let me try to cover here only. TTKG, transtubular potassium gradient, is of no clinical use. If this current edition of this Harrison is having, don't worry, next edition they will remove it. Most likely. What is this TTKG? It is nothing but they are saying whether aldosterone is acting on the kidney or not. That you will very well come to know from the clinical history and other supporting feature and evidence. Whether it is acting or not, mostly it might not. You will pick up from the history only, and that might be required for the research purpose. Now it is not yet validated. The previously they have told TTKG we will use, and they are finding out mostly it is not working, and TTKG clinically we are not doing. Instead of TTKG, a good diagnostic clinical history and other blood parameters, especially HbA1c, these kind of the things which will give the clue. 24-hour urinary potassium can add a bit clue in very diagnostically dilemma cases. 24-hour urinary potassium might be of little helpful to make sure whether the patient is taking excess or not. A high intake dietary pattern, if it is not asked, probably that time it might be helpful in the OPD setting. IPD you will easily solve, diagnosis can be easily made. So let me put 2 or 3 points in with respect to the clinical picture also. Clinical picture only 2 things. Any kind of arrhythmia, muscle weakness. Arrhythmia, yeah, simple mnemonic is tips. Tall T wave, interval prolongation, P wave disappearance, sine wave pattern. Level is also there, 6.5, 7.5, 8.5, 9.5 milliequivalent. Above this, these tall T wave, interval prolongation, P wave disappearance, sine wave pattern can occur in ECG. But any kind of arrhythmia can occur for that matter. Any block, sinus block, first degree block, second degree block, complete heart block, anything can occur. Asystole, ventricular fibrillation can occur. And in the casualty, if you see a patient who is more than 50 years presenting with heart block, only 3 differential, either it could be MI, either it could be hyperkalemia or degeneration of the conduction system. In that, hyperkalemia is an important differential in the heart block. So hyperkalemia, you should be knowing it presents as heart block. And one more feature is it presents as muscle weakness, more common in the younger age rather than the older age. Treatment, just outline I am telling, it can be acute and chronic. First, to treat it, you should know the etiology. Etiology you will get from the history only, don't worry. So acute and chronic. Acute, stabilize the heart with calcium gluconate. 10%, 10 ml you can give over a period of 5 to 10 minutes. Here, again Harrison says the effect can come in 1 hour. Clinically you can't wait for 1 hour. If it is because of CKD, ECG changes are there, take it for dialysis. Why I am telling? Because first year resident are blindly following, let us wait for 1 hour as given in the Harrison. No, it depends on the patient risk. If ECG changes are there, take it to dialysis in the acute. Second, try to push the potassium into the cell by giving beta agonist, which might cause some kind of tachycardia as a side effect of that. And insulin with the glucose, which pushes the cell. This is the acute. Chronically, diuretic, hemodialysis, potassium binders, polystyrene sulfonate, patitomer, zirconium ions, their latest in the sense last 3-4 years it is in the textbook, and clinically also we are using patitomer, zirconium sulfate, these binders. And one more thing is diet restriction. So management acute and chronic management, immediately you act. This also should be added, depends on the overall situation. Diuretic, hemodialysis, potassium binders and the diet. 4 components in the chronic, acute 3. First, stabilize the heart with the calcium gluconate, push into the cell. Beta agonist and the glucose with insulin. Beta agonist, take a patient-centric decision. So this is all regarding hyperkalemia, which a medicine resident clinically require in casualty want to manage. And again, don't go with the absolute value or absolute test which is required. Go with the generalized approach, because hyperkalemia is not the only value you are going to handle. You are going to handle patient as a whole, ask the history and solve it. So let me see the time. Okay, let us close the video here. In summary, high potassium, only 3 causes: increased intake, decreased excretion, shift. Before that, rule out false rise in the value. In the decreased excretion, acute kidney injury, CKD or RAS arc blockade. Renin, angiotensin, aldosterone arc blockade. Arc could be blocked most commonly because of diabetes, because of the drugs. Diagnosis, ECG, clinical feature, history will easily solve it. TTKG, we are not using. Extra information if you want, 24-hour urinary potassium might be helpful. Which is the most important clue? Age and the comorbidities is the most important clue. ECG, that changes will be there. Any kind of block, muscle weakness can be there. Treatment, acute and chronic, we discussed already. Bye bye, we will see in the next video.